J'ai différentes facettes. Je suis la chercheuse, je suis la grooveuse, je suis la diva, je suis aussi la psy, je suis la maman, je suis la sœur. Je suis un peu tout. Le domaine de la science dans lequel je travaille, ça s'appelle l'immunométabolisme. Quand j'ai postulé pour le départ pour commencer mon PhD, j'étais enceinte. Les gens ont énormément douté de moi, à tel point que moi-même, j'ai aussi douté de moi. Je ne pense même pas qu'elle peut faire le labo. Tu as vu ses ongles? Elle est trop dans la beauté, elle passe des heures à faire du make-up. Mais c'est là où j'ai puisé ma force. Je me battais contre leurs stéréotypes. Je ne vais pas échouer. Avec les sacrifices que j'ai faits, j'ai laissé mes enfants derrière. Ils vont dire, maman, maman, tu ne nous as pas laissés pour rien. Voilà, je leur dois bien ça. Moi, quand j'ai commencé mon PhD, je me sentais tellement unique. Je regardais autour de moi, il n'y avait pas de modèle. Depuis, j'ai travaillé pour être ce modèle, quelqu'un qui ne rentre pas dans toutes les cases. Il y a certains programmes de PhD où on n'autorise pas des femmes enceintes à postuler. D'autres donnent même un minimum d'années et pas avoir de grossesse. On doit enlever ce genre de restrictions, que ce soit implicite ou explicite. Ne n'avoir personne. Moi, je plaide pour qu'on ait des programmes de PhD pour des femmes qui soient flexibles. On doit, au lieu de mettre des interdictions de prendre des grossesses, on doit plutôt inclure. Les femmes doivent faire la science avec leur patrimoine. Moi, j'aurais eu mes enfants avec moi si j'avais un support pour la prise en charge des enfants. Je ne les aurais pas laissés. Peut-être que j'aurais été beaucoup plus performante encore. Et j'aimerais que mon histoire puisse inspirer d'autres personnes. C'est difficile, mais ce n'est pas impossible. Pas avoir peur, de faire des choix qui parfois semblent difficiles, mais de les assumer. Parce qu'un choix qu'on fait pour soi est toujours bon que le choix qu'on fait pour les autres.
Good morning, distinguished guests, speakers, and delegates. I'm delighted to welcome you to the second plenary session of the 12th EDCTP Forum. My name is Christina Obiero, and I'm a clinician scientist based at the Kenya Medical Research Institute, Wellcome Trust Research Program in Kilifi, Kenya, where I lead research investigating the etiology, diagnosis, and treatment of serious infections during the neonatal period. Antimicrobial resistance is now at a critical tipping point, with the number of deaths expected to rise sharply. My context in rural Kilifi, similar to most healthcare settings in Africa, is that of increasing antimicrobial resistance. Today, Dr. Chanda will be speaking on antimicrobial resistance and its implications for Africa. Please join me in giving Dr. Chanda a warm welcome.
Thank you very much for that warm introduction. I will probably spend some time just to give an overview of antimicrobial resistance, but I noted that when I came here, the discussion was already ongoing. So some of the things that I'll probably highlight will not be something new, but it will just be something that we have already discussed, especially in the sessions for yesterday. So antimicrobial resistance is more of a broad term. It covers antibiotics, antivirals, antiparasitics, and these are essentially medicines that are actually used to treat infectious diseases, cutting across animal, human, and also some in the environmental sector, especially plants. I would like to make this particular distinction between antibiotic resistance and antimicrobial resistance because most of the interventions have been tailored towards antibiotic resistance and not necessarily addressing all the other elements covered within antimicrobials. Then I would also like to bring it to the House that antimicrobial resistance is actually a natural occurring phenomenon, but it has been exacerbated by poverty and also inequalities, and mainly has affected countries across regions and across different levels of income. As of 2021, it was reported that 4.71 million people died or suffered from drug-resistant infections. Facilities, there is poor access to water sanitation, and there are also poor IPC measures. Then on the community side, there is limited education or awareness, and they don't also have access to water and sanitation, and they have poor adherence practices when it comes to infection prevention. When it comes to access, the most important aspect to realize is that because of the growing population and also the lack of infrastructure, there are challenges on both sides. There is a challenge where there is access to the health services from the community side and also the inadequacy in terms of providing services from the health system. For diagnostics, it covers both the lack of capacity from the human resource, and it also covers the lack of access to diagnostics within the infrastructure which is already existing. Then on the human side or community side, there is incorrect diagnosis and also delayed diagnosis, and there is also poor access to diagnosis that should actually be available at community level. With treatment, we realize that there is a lot of weak regulation when it comes to over-the-counter prescription of antibiotics and also the quality of treatment which is actually provided. On the community side, there is overuse of antimicrobials, why this is also partly driven by the fact that there is also inadequate access to the facilities that should actually offer the correct service. As a continent, Sub-Saharan Africa faces a human crisis. It houses or is home to about 13 million or 13% of the world's population, but it carries 25% of the world's disease burden. But despite the fact that the continent has 13% of the world population, only 1% of the human expenditure is spent on the continent. From the economical side, it's important to note that 3/4 of Africans live on less than $2 a day, and nearly half of the population survives on $1 a day. Then it also suffers from human resource shortage, with an average of 1 doctor for every 10,000 people, with an expected shortage of 4.3 million doctors by 2035. Then there are also challenges in terms of inadequate infection prevention control, with lack of comprehensive wash facilities, and also 84% of facilities do not have effective infection control procedures in place. Then I've already highlighted the challenges in terms of access to diagnostics and also services within the continent. And in terms of the AMR burden, in 2021, it had over 1 million deaths associated with AMR, with 25.2 million lives that could be saved in Sub-Saharan Africa by improving health services and also access to antibiotics. Then developing countries across Africa would lose up to 5% of their GDP as a result of AMR. And if action is not taken, AMR would cause a forecasted 30.35 million deaths between 2025 and 2050. There is an aspect that we have to also consider when we are looking at AMR, which is the societal burden that AMR actually poses. And it's quite important to note that in terms of the population distribution, we do have a vulnerable population on the continent that has experienced AMR in one or the other. So there is an aspect of the lived AMR experience that we have to factor in. And when we're designing interventions, it's also important that we also incorporate the community as critical stakeholders, and we have to understand that AMR has got a societal component which has to be fostered in terms of behavioral change. So the question is, what progress has happened since the Global Action Plan was developed in 2015? As a continent, we have made headway. As of 2024, there were about 46 countries that had already developed national action plans to address AMR, but I would like to indicate that these national action plans, in as much as they have been developed, there are different stages of implementation, with particular challenges that will be highlighted later on in the presentation. Then when it comes to policy and governance, we have made a lot of progress. We do have frameworks at regional level, and we do have frameworks at national level with antimicrobial resistance coordination committees being established within countries and being anchored within the national action plans on AMR. With surveillance, a majority of countries do support submission of data to GLAS, and many of the African countries have also enrolled and report priority pathogens on a yearly basis. With capacity building, there has been investment over time in terms of human resource targeted towards raising awareness, infection prevention control, stewardship intervention, surveillance, and biosecurity. This has been supported by a number of partners, including the Quadripartite, World Bank, USAID, CDC, and Fleming Fund. Then we have to appreciate that under Fleming, there have been establishment of regional sentinel sites, which have also been strengthened by the Pandemic Fund to enhance AMR surveillance, and also strategically located in countries with high disease burden. Then a number of countries have also adopted the AWARE categorization and have included them within the essential medicines list. This slide is a busy slide, but it also just shows the journey from the time when the Global Action Plan was enacted in 2015, all the way to the establishment of the Interagency Group on Antimicrobial Resistance, to the Muscat Manifesto, and the interesting high-level meeting at the UN General Assembly in September last year. So there has been a lot of commitment on the global space, supporting the interventions that actually address antimicrobial resistance. As a region, we have had adequate responses which have been covered through the establishment of the AMR Common Position for the control of antimicrobial resistance, and also the establishment of the task force on AMR by the African Union. And there is also a framework that addresses the containment of antimicrobial resistance between 2020 and 2025. And there is also the establishment of the African Union Interagency Group on One Health. This slide just highlights the progress that has been made from 2017, highlighting the steady increase in countries that have now developed and implemented national action plans from the initial 15% to the current 83% in 2023. And the interesting part is that of these 83% that already have national action plans in place, 28% of them have the national action plans costed, and they also do have a monitoring and evaluation framework in place. So, what is the current status when it comes to addressing interventions relating to AMR in relation to the global average? So Africa lags behind when it comes to addressing the drivers relating to AMR, especially where IPC and WASH is concerned, where the global average is 39%, but Africa still stands at 13%. And when you look at building evidence and improving the reporting, when it comes to looking at the setting baseline due to surveillance systems, we are still at 11%, whilst the global average is at 19%. And the same thing applies to mobilizing and coordinating resources where governance is concerned. We're still lagging behind as a continent, 9% with the global average of 23%. But the interesting thing with this current picture is that in as much as it looks really gloomy, when it comes to stewardship interventions and integration of AWARE, we are above the global average, which is 47%, but as a continent, we are at 57%. When it comes to looking at the pathogens of interest, it's a bit sad to note that in as much as we do have data that has been generated, the categorization in terms of the priority pathogens, the pathogens of interest for Africa don't actually rank higher than medium on the WHO list. And on that particular list of note is that the ones that we are mainly interested in is Klebsiella pneumoniae, which actually impacts a lot of sub-Saharan countries, and it has got the higher prevalence when it comes to resistance with third-generation cephalosporins. Then the other pathogen of interest is Streptococcus pneumoniae, which is essentially supposed to be covered under the vaccination program, but it has also had problems with the emergence of resistance to macrolides. The important thing to note here is that there are two important pathogens that cause bloodstream infections, Staphylococcus aureus and also Klebsiella, that have been included as part of the indicators, as part of the specific indicator monitoring bloodstream infections attached to the SDG3. Then here, the important thing is that as a continent, by the virtue of just implementing IPC, WASH, and vaccination, we would actually avert close to 2,000 deaths associated with AMR by targeting these simple long-hanging interventions. When it comes to IPC, it would avert about 7.8% of the deaths associated with AMR, and WASH would cover about 5.7%, with vaccination programs would also covering about 4.2%. Consolidated, the overall would actually avert about 18%. So this I will go over because some of the components might actually be repeated. But in terms of the challenges for implementation, the challenges range from inadequately financed national action plans, which is a big challenge. Most of the national action plans are financed due to external funding. There is very little internal resource mobilization, and very few national action plans are funded by the governments. Then when it comes to governance and coordination, there is a problem or challenge when it comes to coordinating activities across the One Health ecosystem, and also just coordinating activities within the actual sector, whether it be animal, human, or environment. Then there is a gap when it comes to technical expertise, especially when it comes to the personnel required to coordinate AMR activities, as they are not designated individual roles. They cover AMRs as part of their extra activities. When we look at political will, in as much as my slide actually says that there is lack of political will, the political will is there. The challenge which is there is this particular political will translating into countries allocating budgets and also prioritizing activities relating to implementation of AMR. Then when we look at awareness, within the One Health, levels of awareness are relatively high on the human side, but when you compare to the animal and environment, the other two sectors are lagging behind. Okay, then looking at the challenges in terms of financing, it's quite clear that AMR is not a financial priority when you look at the national budgets that have been passed within the region, and there is also limited financial support for sustainable NAPs on AMR. And the other challenge which is there is that there are inconsistencies in data on AMR research and development, which would actually foster financing. And there is also uneven investment on AMR-related R&D across sectors, with the human sector taking lead. Then there is also need to have incentives for antimicrobial marketplace in order to support innovation. With the current funding for addressing AMR, which is about 10 times lower than the funding for other diseases, many African countries' national action plans are also inadequately funded. I've already touched on governance relating to weak coordination structures and also insufficient regulatory enforcement. And there is also a lack of transparency and accountability. When you look at political, we already highlighted sufficient allocation of resources and also inconsistent policy enforcement. With surveillance, we do have a bit of data when it comes to surveillance, but there's still issue would also mean that we have to address the use of antimicrobials in the animal sector. The usage of antimicrobials in the animal sector is actually much higher than that estimated on the human side, as illustrated by the estimation in terms of production. When it comes to looking at the production of 1 kg of beef, you're looking at 45 milligrams of compared to 12. But I would just like to draw attention to the fact that when you look at the funding directed to antimicrobial resistance compared to the other priority areas, you realize that the funding for AMR is 10 times lower than the funding which has been made available for malaria, TB, and HIV. 2 to 6 billion per year in order to actually finance the interventions of the national action plans within the region. And this particular estimate was obtained from the World Bank and the GOG economic modeling. Now comparing the 2 to 6 billion per annum required for AMR interventions compared to the 100 million that was put in the political declaration, you actually see that there is actual need to mobilize our resources in order for funding to address the interventions addressed in the national action plans within the region. Then if this particular funding is made available, the implication is that we can actually avert over 200,000 deaths per year, and this literally just entails spending on interventions that are already in existence, which include IPC and WASH. This slide just makes a case for return on investment if interventions are implemented according to what has been projected, with globally having a return on investment for every dollar between 7.2 and $3.1 based on the 2020 to 2050 estimate. And there is also a potential saving in healthcare and work productivity of up to $7.7 trillion between 2020 and 2035 if the interventions are quite effective. Then the other thing which is important here is to appreciate the estimated annual average savings in health expenditure from AMR, which would be about 33 million per year in Africa. So, having talked a lot about all these other components, the question is, what are the actual priorities when you're actually looking at Africa? The priorities range from having strengthened governance by establishment of AMR central coordinating bodies at higher government levels, and also addressing AMR drivers, specifically targeting IPC, WASH, and vaccination, and also supporting the build-up of evidence to strengthen surveillance and also data sharing platforms, and mobilizing resources in order to close the funding gap to support the implementation of activities. Then there is also an important aspect of community engagement by launching comprehensive education campaigns that are highly contextualized to the communities within different settings. Then there is also a need to further look at research and innovation with increased funding and also enhance our research infrastructure. That's all I had. Then I would just like to say thank you very much for having provided the platform. I know AMR within the TB space is a new concept, but like I had indicated earlier to the moderator, When I came, AMR was being discussed as part of the agenda without really necessarily saying it's AMR. For us, it's more of a broader term, which actually encompasses TB interventions and also HIV. And it will be quite important to see the similarities between what has already been in existence within the TB space and HIV, and also acknowledging the fact that there are a lot of similarities in terms of what the challenges have been overall. So thank you very much.
Thank you very much, Dr. Chanda, for that very interesting and insightful talk on AMR. And I'd like to request you to remain on the stage as we open the floor for the question and answer session. So if anyone has any questions, kindly, so you have one at the front and one on the other end. Do you have a microphone? Or I could, yeah. I can start with Dr. John Amwasi.
Thank you very much, Christina, and thank you for that presentation. I've just been reflecting on the issue of the funding gap for AMR. It is clear that the burden of disease alone in demonstrating its impact does not cut it, because if it was that simple, then money would go where the burden is highest. You realize that AMR, well, is couched as a disease, but in reality, it is a constellation of factors and not really your classic disease in and of itself. So what do you think should be the approach towards bridging this funding gap, which will only get larger simply because the problem itself is going to get bigger, given that the traditional approaches have not worked, and it's clear that just the burden alone and presenting these kinds of statistics will not necessarily motivate investments? Thank you.
Thanks.
No, thank you very much for that. That has always been the most interesting question when it comes to funding an AMR. When somebody actually steps back and looks at AMR, it's easy for a lot of people to actually miss the fact that when you are looking at what you're so the question is, what are we actually addressing? What we're actually addressing is a poor health system, which has a lot of inadequacies, and because of the challenges in terms of healthcare financing, we have ended up with a byproduct which we are essentially calling as antimicrobial resistance. So in a very simple term, I'll probably say that if we have to address AMR, we have to go back to the basics. We have to look at what are the building blocks of a healthcare system, and we have to now start strengthening that particular healthcare system without necessarily saying that we're actually addressing AMR. And it's interesting that you highlighted the fact that it's a constellation of a number of actors or factors. The reason why it's very difficult to even explain, even at community level, what AMR is that it can't really just be attached to one particular entity. It's a number of things. It's multiple things coming together and giving you one particular condition. So even when we're looking at AMR raising awareness at community level, it has always been a challenge as compared to TB and HIV that have always had a much easier way to actually communicate it. So in a very simple and rational way, I'll probably say that we have to take it back, go to the basics and strengthen those particular components that we have neglected. We have to go back to the Abuja Declaration and ensure that as countries, we allocate 15% of our national budgets to healthcare financing, not AMR, but healthcare financing. We strengthen our health systems. Then, in the long term, I think it would be more sustainable to approach it in that particular way.
Tachanda, for that response. We have a question we have one at the end. Do you have a microphone to the other end? Yeah. You can take that question.
Thank you. So my name is Abna Pukwewuku from Medicines for Malaria Venture. I like the fact that when you began, you talked about AMR not just being about antibiotics, but also about parasites. And I'm saying that because you mentioned HIV and TB, but in the malaria space, one of the biggest issues we're having is the fact that in Eastern and Southern Africa, we're experiencing resistance to some of the medicines. And if there's not a lot of awareness of this, then the countries can't make the ask for R&D into new medicines. So it's more of a comment that we need to look at things, especially when we talk about AMR, to broaden the picture a little bit more, and to accept the fact that also there is a lot of resistance to pathogens, not just even for malaria, TB, and HIV, but for many other diseases. And the countries have to be the ones building the surveillance systems to monitor for some of these so that we're aware of it and creating a drive for greater R&D into interventions to support this. Thank you. I think there's another question.
Good morning. Thank you so much for the elaborate presentation. My name's Beatrice Chison Kasambwe. I'm coming from Malawi, University of Health Sciences, College of Medicine. So my question is asking on the governance structures that have been put in place. You've highlighted the burden of a use of antibiotics in beef production and poultry, which is an issue as well as where we are coming from. And my question is, what are the strategies that will be valuable in terms of implementation to make that there's a balance between those that are in the poultry sector as well as in human health?
Thank you. So I'll probably start by answering the question regarding the governance structures relating to the implementation of activities in the animal sector. The animal sector has, when countries were developing national action plans, they drive to develop that particular document, or what actually went into that particular document was actually driven more by the human sector, because at that particular point, the human sector had the most information to feed into the situation analysis. So the challenge that has always been there is that there has been inadequate representation at country level when you look at the other two sectors addressing issues in the animal sector and also the environmental sector. So what I would probably say is that when it comes to addressing the misuse of antimicrobials, the animal sector is still stuck at the point where raising awareness is quite a critical issue, and also educating the technical people within that particular sector of what antimicrobial resistance means for the animal sector. For the human sector, it's a lot easier when it comes to controlling for the use of antimicrobials, because humans are the ones that use antimicrobials in the human sector, as opposed to the animal sector, where the one who actually prescribes the antibiotics is actually a human, but the one that the animal is the one that ends up consuming that particular drug. The other thing to note is that there has to be a scaled-down approach when it comes to implementing these particular activities, and as much as they're included in the national action plans, the activities have to be implemented at community level where the extension officers are actually present. So going back to the very beginning, it's all about mapping stakeholders and also ensuring that when activities are being prioritized, the activities are not just being prioritized from the human-centric view, but there is also an incorporation of activities that would actually cater for the animal sector, and especially that when you look at the animal sector and the impact when it comes to food security and also trade, that particular aspect cannot be ignored.
We have one more, we have 2 minutes for one more burning question, so let's take one from that end.
Yes, Marion Koopmans from Erasmus Medical Center in the Netherlands. I was struck by your survey of the medical laboratories and seeing that only 1% of them seems to have core capacity in bacterial diagnostics. So we hear a lot of individual pathogen-focused diagnostic strengthening programs and the genomics, but what in your view is needed to really get the core capacity up and running? Because to me that seems like a missing element.
Thank you. So the interesting part is when people are looking at the drive to have genomic testing and have molecular platforms really available, the question that I've always had is where are you getting the pathogens that are feeding into your pipeline? And if you look at, as a continent, having surveyed about 370 laboratories and only having 1.3% doing bacteriological testing, it basically tells you that there is still a limitation when we are looking at the actual surveillance, even before we get to the genomics level. So what is actually required is to strengthen the capacity for labs to actually conduct the extensive profile when it comes to both culture and sensitivity, and also to standardize this particular testing by either using CLSI or UCAST. Then the other important aspect is we have to look at other models that have actually worked, because the other challenge when it comes to financing labs in Africa is that we have got too many labs essentially doing the same thing, and there is also a challenge when it comes to having access to equipment for testing. So there has to be a model that would actually allow us to have the capacity that is required for us to do mass testing. In this case, having a model where you have a centralized lab system as opposed to having small mini labs would actually answer that particular question, because then it would become a lot easier to improve the quality and also standardize the testing across different platforms. But the other aspect that is important to note is that what was highlighted is passive surveillance. There is no country that does active surveillance, and that's the other challenge within the animal sector in our region, because we don't do routine microbiology for animal. We only do it when there is surveillance-related activities that are carried out at a periodic point. So all in all, centralize and also improve the capacity for routine bacteriological testing before we strengthen the molecular testing. Thank you.
Very much, Dr. Chanda, for your insightful presentation on AMR. And I'd like to ask you to join me as we give a round of applause for Dr. Chanda. Thank you. So I'd also like to thank the audience for your active engagement during the session. And we continue to encourage equitable and evidence-based research and development to address the critical gaps in AMR in Africa. So we'll now shift to a more exciting part of the session, which is where we get to know who wins the EDTCP Outstanding Research Team Prize Award. And this will be led by Dr. Henning Gadeke. Dr. Gadeke is the Deputy Head of Unit in the Global and Public Health Research Division, Federal Ministry of Research, Technology and Space in Germany. He serves as the Chair of the EDCTP Association Board and Chair of the Global Health EDCTP Joint Undertaking Governing Board. Welcome, Dr. Gadeke.
Good morning. It's a great pleasure and honor to present the EDCTP Outstanding Research Team Prize today. And I would like to extend my sincere congratulations to all nominees and express my appreciation for your outstanding contributions to global health research. The EDCTP Outstanding Research Team Prize consists of a recognition trophy and a cash prize of €50,000. EDCTP was looking for a team that has both scientific excellence and impact. Scientific excellence, of course, in the EDCTP's program priority issues in poverty-related diseases. Impact, by building effective and equitable South-North partnerships to answer the priority research questions. This involves producing health policy relevant deliverables, such as research data implemented into policy and practice, high impact publications, and significant capacity building outputs at local research sites. The winner does this for more than 35 years, longer than EDCTP actually exists. It's a perfect example of how long-term cooperation of African and European partners can lead to results that really make a difference in people's lives. This team has no core funding, but its successful funding portfolio is a testimony of the team's outstanding work. The team continues to produce PhD, which is an important investment in the next generation. Its work directly impacted HIV and TB policy and practice, such as the WHO TB/HIV guideline development. The key members of the team include Dr. Kwame Shanaubi, Professor Helen Ailes, Dr. Musonda Simvingwa, Professor Virginia Bond, Abshab, Maina Chipa, Chepela Ngulube, and grant administrators Heitler Muleyer and Jeanette Hedstrom. The EDCTP Outstanding Research Team Prize goes to Zambert Research Unit from Zambia. Please welcome Dr. Kwame Shanaubi, Executive Director and African Team Leader, who will accept the prize on behalf of the team.
The kind of work that we do, research, sometimes it takes time for the impact to be seen. But we are strong believers of the work that we do, that eventually it does pay off. I'm the Executive Director of Zambert, a Zambian registered non-governmental organization. We're a team of highly skilled people in terms of carrying out large population-level trials. Our expertise is quality, multidisciplinary public health research that can influence policy and practice. Our focus is on really TB and HIV-related work. The largest HIV prevention trial that was done in Zambia and South Africa, it was actually being conducted by Zambert. The aim of that trial was really to find out whether a combined HIV prevention package could reduce community-level HIV incidence. We employed over 500 community health workers that were going door to door, testing people repeatedly, encouraging people to start antiretroviral treatment regardless of CD4 count. Previously, people had to wait until their CD4 count was at a certain level before they could start antiretroviral treatment. But as a result of this contribution, now people that are HIV positive do not have to wait before they start. This HIV prevention package was actually able to prevent new infections by 30%. Zambert and this research team has actually been making a difference for a long time now. We have contributed to WHO guidelines in terms of starting antiretroviral treatment. We have contributed to guidelines around TB screening. We have contributed to guidelines that have to do with HIV self-testing. We design our questions based on what needs to be answered. At the end of the tunnel is making a difference in terms of ending AIDS, ending TB as a public health threat. And it's not just TB and HIV. It actually extends to non-communicable diseases. It extends to neglected tropical diseases. The research is so current, is so timely that it just keeps you going. It keeps you going. We need to do more. We need to do more in terms of making sure that researchers and policymakers work together. We need to do more in ensuring that whatever research is produced in the country level can be translated into policy. My drive has been in changing the lives of people.
Well, good morning. So, as has been introduced, my name is Dr. Kwame Shanaubi. I'm the Executive Director for Zambert. Allow me to express my heartfelt gratitude to the Global Health EDCTP3 joint undertaking for this prestigious award. Your recognition of the Zambat research team as the outstanding research team for 2025 has re-energized and refueled us, and we are honored to receive this recognition. I'm standing here today representing the Zambat research team, and I'm grateful for their outstanding dedication and commitment for global health, particularly in the area of TB and HIV. From the time that Zambat was conceived in 1988 as a collaboration between the London School of Hygiene and Tropical Medicine and the University of Zambia School of Medicine, this team has enabled the organization to grow and thrive, marking over 35 years of impactful public health research. This award is a testimony of our tireless efforts and passion in conducting high-quality research that addresses pressing health challenges. Despite operating without core funding for over 35 years, we have remained steadfast in our pursuit for excellency. This recognition inspires us to continue pushing boundaries and pursuing research that impacts health policy and practice. Zambat currently has a diverse portfolio of about 23 research studies. Our expertise spans across conducting large-scale trials, epidemiological studies, randomized control trials, as well as implementation research. We are recognized for strong expertise in community engagement and social science, having spearheaded TB, HIV stigma work. Our success is attributed to strategic partnerships and collaborations. Our networks span across sub-Saharan Africa and Europe. The Zambat research team is deeply invested in capacity building. We pride ourselves in training the next generation of public health researchers. We collaborate with regional and international institutions to strengthen research capabilities. Zambat hosts and supports MSc and PhD students. Our team has hosted and mentored research fellows for the EDCP3 funded project on capacity development for disease, outbreak, and epidemic preparedness in sub-Saharan Africa in collaboration with CDC Africa. We're also part of the CREATE PhD program, which is training a blend of 50 North-South fellows from the UK and Africa in global health. We are part of an ongoing EDCTP3 capacity building grant called SOFA, which aims to train 6 PhD and 2 postdocs and 4 MScs. Zambat is still open to exploring networks and collaborations that will contribute to our mission and vision. Our mission is to contribute to global public health policy and practice through the generation of evidence base by conducting high-quality research. By establishing and maintaining strategic partnerships, we continue to contribute to achieving quality universal health coverage both on a local and global level. Lastly, thank you so much to EDCTP and all our past and present funders, without whom this work would not have been possible. To the Zambat research team, a well-deserved congratulations. We will continue to do more to impact research and development to improve health for all, even in challenging times like now. Lastly, but not least, I would like to thank my Lord Jesus Christ, who has enabled us to do what we do. Thank you so much.
Thank you very much, Dr. Shanobe, and congratulations to the Zambat team on a well-deserved award. Indeed, the Zambat team serves as a great example of how teams in Africa can work together and develop impactful and have impactful outcomes towards improving African livelihoods and health outcomes. With that, we've come to the end of our session. So I would like to invite forum delegates to the refreshments area for a 30-minute break. And I'd also like to remind you of the parallel sessions and the scientific symposia taking place directly after this break from 10:30 a.m. Thank you very much for your attention and your participation.
Dorothy, not Deborah Yaboamanu. And and we've got a fantastic symposium that focuses on
trade secrets, and this is the most important when it comes to vaccines manufacturing. So a bit about the medicines patent pool. So we negotiate public health-driven licenses with patent holders. MPP sub-licenses the technology to generic manufacturers or to third parties and provide technology transfer support in the process. MPP's publicly accessible database, MedSpar, enhances transparency of patent and licensing data, and it focuses exclusively on LMICs. So manufacturers in LMICs are supported to produce, and then they supply countries. In some instances, royalties are paid to originators. So far, we have signed licenses with 22 patent holders, and we have signed agreements with 72 manufacturers across the world, delivered 44 billion treatment doses in 148 countries, and we project that savings will be 3.9 billion US dollars from the fact that lower cost products are reaching patients and health systems have additional money to deploy to other uses or to provide more health products. And of course, thousands of lives saved. So in order to provide some example of how our model works, I will use just two products. Without IP, or in the absence of IP license, generics typically enter the market only after patent expiry. So dolutegravir is a typical example, and there is also a combination product called TLD that includes dolutegravir. This product was discovered about 20 years ago, and it's patented until 2026. It is for the treatment of HIV. MPP and ViiV signed a license agreement in 2014. 10 years later, 24 million people are estimated to be on this product. And that constitutes about 80% of all people on ART worldwide. Full WHO recommended regimen costs just less than $40 US in a year, and is the lowest price for any first regimen. So the product has been supplied in 128 countries. Another example relates to COVID-19. During the COVID-19 pandemic, we signed an agreement with Pfizer, and the first generic of that product for nirmatrelvir ritonavir was supplied in 16 countries before the COVID cases started to go down, thankfully. Without the license, it means that this product, affordable versions of this product cannot be available until 2035 or 2038, depending on the molecule. So there's also the example of technology transfer. I'm not going to talk too much about this. The previous speakers have highlighted this. It's a multilateral model based in Africa. The hub is in Afrigen. and technology from there is transferred to partners across 14 countries. Through the program, we expect that 10 manufacturers could produce mRNA vaccines for human use by 2030, if suitably funded. So, since we are talking about clinical trials, research in this meeting for this week, what could the research and development community do in order to facilitate equitable access to health products? It is important to consider access from the outset, from the point of ideation. Embedding access conditions such as licensing and technology transfer in research and development funding agreements could establish a foundation for earlier and more equitable access to the products of innovation in LMICs. The pandemic agreement that was adopted last month during the World Health Assembly, in my view, is setting the stage for a shift in terms of the norms of how we run, how we ensure equitable access. Article 9 of that document actually requests countries to ensure that they include access conditions when they fund R&D. So that way, we are setting the ground for when the products gets to be available, then access can be guaranteed. And access could be through licensing, technology transfer, and several other mechanisms. So we contribute as MPP to this by leveraging our experience and expertise in upstream licensing. Since 2021, we have been working in this space, including embedding affordable access provisions in research funding agreements, particularly in universities, in research-based or research-focused universities. So this is where I stop. I want to say a big thank you to IVI, EDCTP, and to you, the great audience. Thank you.
Thanks. We're coming close to this second part after the dignitaries, the excellent presentations. Now, how do we communicate what we do? I think it's important as well. The work that Prof. Padma Shri is doing, Prof. Petro, MAF Plus, and a lot's been done, but we don't communicate properly. I think it's good that we get some feelings, probably feelers from the communicators. So I'm inviting here Dr. Ben Johnson, Editor-in-Chief of Nature Health, to tell us about how science can influence health policy. So, Ben, you have the floor.
Thank you, Professor Nicaise, for that introduction, and thank you to IVI for organizing this really important symposium. While I wait for my these different set of slides I'm waiting for. I'm an editor at Nature, and Nature's been publishing scientific research for about 155 years now, and we like to think that the research that we publishes has impact, but the reality is publishing a paper in Nature or indeed in another scientific or medical journal is no guarantee of real-world impact. Indeed, some of the papers we publish have no real-world impact. And so as a journal and as a family of journals at the Nature portfolio, we're increasingly trying to think, how can we ensure that the research that we publish has real-world impact? And in the case of health, how can we make sure the research we publish impacts health policy and health practice? Because there is a gulf, there is an implementation gap between research published in scientific journal articles and policy written by policymakers and decided on by politicians and clinical practice. And there are barriers, implementation barriers between this. And this is very relevant to the discussion today because vaccine development requires scientific research, yes, but it also requires investment in infrastructure. It requires tackling social issues, cultural issues. It needs financial investment. It can lead to economic development, but requires economists to think about it. So in terms of health, what we've decided to do is launch a brand new journal. So a short plug for the new journal I'm now leading, which is Nature Health. And this aims to bridge the implementation gap between health research and health policy and practice. And we'll be prioritizing research that is conducted in resource-limited settings and research that involves patients and communities. And this is really my main slide. This is the way, from my desk in London, editing papers, how I think we can try and ensure that the discussions that we're having have real-world impact. One is actually rethinking what we mean by impact. For academics and scientists, impact is often the number of papers you publish, the number of citations that you get. I would argue that we need to think about real-world impact, and we need funders, universities, and institutes to measure the success of academics based on the impact that their research has in the real world. Secondly, and this is probably the most important in my opinion, scientists and researchers need to involve patients and communities. And I've seen some fantastic examples of community engagement around Mpox trials earlier this morning. This is so critical because when you co-design your research or when you involve communities in decision-making, you get better research, you get more sustainable research. It's also now required, as of this year, by an amendment to the Declaration of Helsinki, which is the foundation stone of medical ethics, now requires meaningful engagement with participants and communities. And also, those communities are then advocates. They're powerful advocates with policymakers and with other organizations, with people who have power. Often patient advocates can be much more powerful in persuading than scientists or researchers can. Thirdly, I think as a community of people working in medicine and public health, we need to understand behavioral science better. So changing policy is actually insufficient to encourage healthy behavior. And we see that more than anything with vaccines, where we see an increase in vaccine hesitancy, often for very good reasons, very legitimate concerns about vaccines that you can only address by listening to communities. And we need to invest in implementation science, qualitative research. And I think we don't recognize enough the importance of social science and how that can drive forward medicine and changes in human behavior. Social science has often been looked down on at nature journals, amongst others, as a slightly lesser science, and it isn't. It's absolutely critical to advancing medicine. Fourthly, we need to become better storytellers. And this is a real challenge because often scientists think that we should deal in facts, not stories. But the people who have no facts are brilliant storytellers, and they are weaponizing their lack of facts. And so we need to be better at telling our stories and learning lessons from those who do tell stories well. Finally, fifthly, when we're thinking about policy and politics, whatever your political system in the country where you live, there's always an importance attached to local politics. So if you're trying to engage policymakers, it's often best to start local. Engage local leaders, engage local policymakers, and also, again, we need to think of what motivates policymakers. And they may be interested in science, they may not. They may be interested in health, they may not. They will be interested in money. And I don't mean that in a bad way. I mean that because money is what builds hospitals, it builds schools, it creates the investment needed for new vaccines. So we've got to be able to think about the needs of policymakers and the needs of practitioners, not just our own needs as scientists and researchers. that's all I have. So thank you, and I'm enjoying to listen to the rest of the debate.
All right. Good afternoon. So let me introduce myself. I just wanted to save some time for us. So my name is Sushant Sahasrabudhe. I'm working with the International Vaccine Institute. And then this is day one. As it happens, basically, we probably got delayed from the start of the symposium. So we are going to start the panel now. So can I invite all the panelists to come on the Professor Petro, Mr. Tiwadio, and Ms. Teresa Soup. So most of the panelists that you see on the podium, they have been here except for Ms. Teresa Soup, who is the first secretary at the Embassy of Sweden in Rwanda. This panel is designed in such a way that we can discuss more about the intellectual property, the technology transfer in view of the vaccine access. What are the gaps? What can be the solution? And I want this to be more interactive. So obviously I'm going to ask some questions to the panelists here. If you feel that there are certain points during any point in the discussion, please come to the podium where there are microphones. And if you can ask your question after stating your name and affiliation, that will be great. So just to start the discussion, again, thank you so much for agreeing to be on this panel, which we believe is very important, as many of you have pointed out. So can I have this first question to everyone, and we can start with Professor Petro, you. And then can you summarize what, as per your experience, has been the obstacle for IP management and technology transfer for vaccine access on the African continent? I think
Will you activate? Thank you. Again, thank you to IVI, important topic. I want to comment around the evolution that's happening on the continent. If we look at the challenges around intellectual property and access 5 years ago, and 3 years ago, and 2 years ago, and today, it's changing. A continent that in licenses, tech transfer, full finished technology as a first wave of building an ecosystem and building a sustainable industry has different challenges from a continent now that engages in technology development, in intellectual property creation. I do believe generally the challenges that we have seen is in our patent policy environment on the continent. Many and most of the patent offices on the continent are non-examining, which means that, and particularly in the case of South Africa, that patent applications are registered. And there are even cases where patents lack novelty and inventiveness, but they are awarded. That creates barriers for an industry, and particularly in the mRNA platform space, create broad-based barriers, not for innovation, because under a BOLAR exemption, we can operate up to a phase 3 clinical trial, but we cannot commercialize. So I do believe the continent has a challenge to ensure that we have the knowledge, that we understand patent systems, that we understand the importance of having intellectual property rights in addition to having technology and production agreements, and that we reduce the cost of patenting. One of the challenges that we faced was the of patenting internationally. And what the solutions are for that, I think, will also change as we evolve and as the industry mature. But policy reform, I think, is a very important one for the continent.
Great. Thank you, Pedro. So can I go to Mr. Tiwa, and then from your presentation, you mentioned about MPP
use or underuse of technology, or even the implementation of the technology could fail. That is first. But before that, before I proceed, there could be conditions where goals are not aligned. Where goals are not aligned, for example, where a profit-oriented firm is to transfer based on pressure for global equity. What can we do in order to make that technology holder to transfer? So that takes me to the second bucket, and that relates to incentives. So companies respond to incentives, and there are different kinds of incentives. There could be buyouts. Governments could decide, or regional bodies could decide to say this particular technology is very relevant for us, and therefore we want to pay for it, and they have the technology. There could also be schemes like split margins, where, for example, a company in LMIC decides to be transparent with its profit and is shared between the technology holder and the sending unit and the receiving unit. In that case, the technology holder already can see the financial returns on their IP. There are several other schemes. Like, for example, MPP, we try to use royalty to incentivize. And royalties are also in, there are different ways we do royalty. There could be royalties that are high, and graded in order to make it a bit more attractive, and graded according to income level of the countries that will benefit from that. Some countries are never charged royalty because they are low-income countries, whereas you could have middle-income countries, paying more. I will move to the next one. I've spoken about two. The other thought, the other policy lever, the other lever is reputation. It's not really a lever, but companies are concerned about their reputation, and it is so that kind of pushed them to want to share. We don't have a strategy to making them feel that that their reputation is at stake, but the work of global players like global health community advocating, communities talking about it, about access, civil society talking about access. You see some HIV conference, you see groups that want to picket and things like that. So that kind of push, some companies to want to share technology. And finally,
great,
policy. I mentioned earlier about the condition or the provision in the pandemic agreement about putting R&D, putting access in R&D funding agreements. That is an example. We need to have a new norm where it becomes something that happens naturally, that an innovation in one part of the world will become accessible to every other part of the world because there is a need to ensure that it reaches everybody. And so we need to start shifting towards that direction.
Thank you so much. Can I go quickly to Teresa Yu? And then I will ask you the same question that I asked Professor Petro on the obstacle that you think for IP and technology transfer on the continent. And developing the African vaccine ecosystem is a humongous task. So from the international community perspective and from European perspective, how can international community help in this process? Thank you.
Let's see, does it work?
Yeah.
Well, thank you for that question, and thank you to the previous presentations. It's been really interesting to listen to your insights. I think from my perspective, so representing the donors in this setting, I think one really big challenge is the fragmentation of the landscape. Also from the donors' perspective, we're supporting different initiatives, tackling various of these challenges, but not really together as one. So if we could just imagine like a more coordinated effort on behalf of regular donors like governments and so on, but also investors, banks, all those together to join forces with one shared vision in a country, then the funds would be used so much more efficiently. And, well, just the coordination as such. So I think this is one of the things that were mentioned in the beginning of the seminar today with the Team Europe initiative. So we heard about it, and the MAV Plus has been mentioned many times. I think that one of the reasons is to coordinate the efforts. I can see it. So myself from Sweden, then we work with Rwanda together with 3 other European member states. And together we can look at the gaps and try to address them together so that we're not doing one thing here and there. And this 360-degree approach that the MAV Plus is, it's really useful at looking at the demand side, the supply side, and the enabling environment. And several of these challenges are then being tackled this way. And on the continental level, I mean, there's support to the African Medical Agency, to the African CDC, to the tech transfer facility. But also there are efforts in specific countries, such as Rwanda, where I'm working together with the Rwandan actors. And we're looking at the skills, the human capital, We're looking at research, but also how to get the research out to implementation or to products. Looking at the entrepreneurship programs, the next steps from research, so to say, clinical trial sites, regulatory aspects, and also an enabling environment for having manufacturing here in the country. So I think with this coordinated effort, this is how we can fill the gaps and make much more use of the quite little funds that there actually is. So thank you.
Thank you, Teresa. Can I come, Professor Padmashi, to you? I think great idea behind APTF. I think this is something that is required for consolidation and facilitation on the continent. So again, the same question that I asked Professor Petro and Teresa about the obstacles that you see, and then in general, what do you think are the policy innovations that are going to help for this IP management tech transfer on the continent? Thank you.
Thanks, Sushant. On the IP management side, I think that there are several obstacles. I mean, several things that we haven't done on the continent that I think we should really need focus on. One is really trying to calibrate intellectual property flexibilities for domestic production. Because a number of African countries, they haven't really changed or implemented intellectual property flexibilities from the perspective of enabling domestic production. This is very important. And this is where actually my colleague Petra was talking about actually novelty, inventive step. You know, these are, how do we define it? What do we define that to be? The second thing I think is commercialization of intellectual property in Africa. It's extremely underutilized and it's underused. So firms need to know how they can commercialize intellectual property. Firms need to have access to commercializing intellectual property in a meaningful way, and it should not be very costly. That's a very important thing. The third thing about IP management is also that we tend to look at licensing as the main way to source technology. Because we look at technology as something that is linked to end products that have already become successful elsewhere, which have been introduced by another lead company. We need to start taking the lead in technology terms in Africa. The way to change that is to look at technology for technology development. Is to look at technology domains that are promising, that are important for the region, and to see how can we actually bring to bear finances, technology inputs, and technology transfer to build those technology domains. So those are things I think that we need to do. We need to start looking at technology transfer, not as end game. When somebody else has brought a product to the market, how do we bring that to Africa? We need to start looking at technology transfer as something that builds capabilities of domestic actors to actually innovate and incrementally innovate or substantially innovate. Both are very important for the region.
Thank you so much. Can I quickly come to Professor Petro on this one? So we have talked about technology transfer quite a lot. So as per you, what are the key components of the ecosystem for facilitating that? And then right now the discussion is really about the manufacturing development capacity. But what do you think about the sustainability and profitability of these ventures in view of the local innovation and potentially as platform technologies? Thank you.
Susan, thank you. Firstly, technology transfer can't happen in a vacuum. I think it is the one process that completely relies on a totally functional ecosystem. Regulatory, a policy environment, intellectual property reform, a skills-based manufacturing capacity, a market reshaping, entire value chain. The continent has a very interesting, again, history as it's developed in terms of technology production, technology transfer, but not necessarily platform technology transfer that allows for innovation beyond just a single product. The continent has traditionally received full finish capabilities and not having received technology transfer, drug substance and drug product capabilities. That now is starting to develop, and I think it is essential for a future sustainable vaccine manufacturing sector on the continent to be able to be end-to-end, to have research development, drug substance, drug product and full finish capabilities. What are the sustainability drivers? The real world operates on a market. Is there a demand? Are we choosing the right products? Are we choosing the right technologies? Are we capacitating the right business models? Technology transfer has to be driven by bankable business plans. And there's a lot of debate around public goods and what is a bankable business plan. But ultimately, we have to meet a demand. We have to transform a healthcare system, both the public health and the private healthcare system, to absorb these products. And Padmasree mentioned commercialization. There are so many models for commercialization. I do believe there's the existing company commercialization, internal commercialization, there's the growth of companies, business plans and strategies, but I do want to make a plea for new venture support on this and on the African continent. If we look at the Africa Startup Report for 2024, a few things stands out. Firstly, the data for 2022, $3.3 billion invested in startups on the continent, went down more than 50%, 1.1 billion in 2024. 200 new startups created on the continent, creating 24,000 jobs. That's important. But what is also important, none of those startups are in manufacturing capacity or new technologies. We have to get that right, because that will build the industry sector. So a call for the venture capitalist also to take a bit of risk and invest in manufacturing capability for cutting-edge technologies and new products.
Thank you so much. So can I then quickly shift to Professor Padmasree, you, and then you presented about APTF. Can you elaborate maybe briefly, because we get this message on the screen now. So what can funders do in terms of getting the better IP strategies when they are funding these initiatives on the continent or beyond?
We've looked always at funding as something independent of technology, and I think that needs to change. Finance is not the only lever that matters. And sometimes when you just make finance available and don't think about a comprehensive development plan for technology, it doesn't really sustain manufacturing. I just want to underscore what Petra said, but in a completely different way. To make something sustainable, you need to bring down the price. But to bring down the price, you not only have to manufacture the end product and lots of the end product, which is the economies of scale argument, but you also need to manufacture all the things that go into that domestically and reduce the cost of transportation and import and tariffs and so on and so forth. How do you do that? Is by building technology more comprehensively across the value chain. And that is what makes it eventually sustainable. That's actually also the thinking behind the APTF, is that just investing in fill and finish and end product development is not going to create a competitive African vaccine ecosystem or a pharmaceutical ecosystem. So that we need to move backwards and think about everything that makes the whole, and how do we build that capacity to make that whole and to make it sustainable domestically. Because Indian firms wouldn't produce what they're producing if they had to import everything from Europe or the US. It would never be competitive. It would not achieve those economies of scale and scope. They would not undercut the price in the way they cut it. So we have to start thinking, how do we make that happen in Africa?
Teresa, can I come to you, since representative of international community on the panel, as well as representative of Sweden here. Can you briefly talk about what Sweden as a country is doing for accelerating these innovations and technology transfer on the continent in Africa?
No, does it? I don't know if it's working. On. Yes, good. It's hard to hear. I didn't really hear the question, I'm sorry, but how we can accelerate all the innovations that are coming, yes. I mean, I agree that funding is really not everything. It's a very good point. And also the funding that comes, this kind of funding is decreasing, and is very, very little of what's actually needed. So we can do other things that it has to be catalytic kind of funding. I think skills building is one thing that is helping, but also to initiate things and to initiate collaborations, and in particular actually to take it further, the innovations, to see to that there are possibilities for people to work together. Also, another important one, when the innovations, when they come a little bit further, it's the de-risking of investments, because it's a very costly thing to grow and to manufacture. So if there are ways that we can support banks and other investors to actually invest, but with less risk, that is also a very good way forward, I think.
Thank you.
Thank you.
And maybe last question, because I think we have to wrap up very soon. Tiwa, maybe from your side, if you can just mention about the 3 major points that you have in terms of how the broader ecosystem elements that we must address for successfully expand the vaccine production capacity in Africa. And maybe in 3 bullet points, we don't have much time.
So maybe even 1. I think that the most important thing is to ensure that countries and maybe the regions and maybe Africa as a continent actually own and drive this agenda. A lot is already happening in this direction. There's need for more to happen. The magnet that pulls investment is environment, the signal from government policy. And so we need to get it right. If that is, if you have the infrastructure in place, water, electricity, etc., the regulatory system is robust. The workforce is good, including the pipeline, and financing, access to financing, consistency in policy, predictable long-term demand, then we are good.
Thank you so much. So I know we are running over time, but thank you so much for all the panelists for joining this session. I think this was great. And then, although I know there are multiple questions that you might have after this session, feel free to talk to each of the panelists. And thank you so much for being very patient with us. Thank you.
Thank you.
Thank you. Thank you. Can we have a panel photo? Can we have a panel photo?
Yeah.
What a wonderful panel. I'm going to attempt in about 5 minutes to summarize this really lively, rich discussion that we've had. And when I edit, Professor Nicaise and others in the room have written for me, and I've edited them at Nature Medicine. And I always ask authors to describe the current situation, why it's a problem, and how to fix it. So I'm going to try to stick to that framework. I think we all know why this is a problem. Less than 1% of vaccines made here in the African continent, very few clinical trials here, each medicine arriving in low and middle income countries much later than in high income countries. And also some more granular detail on that, the lack of training for patent officers, the high cost and the lack of trials here also has a really negative effect on trust and on trust in medicines if those treatments are not tested here. And I think we've had a lot of thoughts from the panel on how to fix this problem. And I was very struck that technology transfer mustn't work in isolation. It needs a full ecosystem. We heard this again and again. It needs to work end to end. We need to be generating the intellectual property here in Africa. Fill and finish is insufficient. Local IP will help tackle local priorities, as well as boost science and lead to economic growth. And we heard how we need to invest in the local workforce here in Africa, from researchers to patent officers. We also need a better alignment of goals, which I think is very achievable, partly through what's happening today, alignment of goals between academics, governments, industrial partners. And it has to be easier and cheaper to commercialize intellectual property here in Africa for long-term sustainability and to bring down the price. And I was very struck at the amount of innovation in terms of regulation happening on the African continent. When I talk to people in vaccine development in Latin America, they look on quite enviously at the situation, the pan-continental innovation and increased regulatory framework here in Africa. We've seen the African Medicines Agency and the African Pharmaceutical Technology Foundation next to each other here in Kigali. And I just want to end with a warning's too strong a word, but a quote from the minister, that the enemy of innovation is bureaucracy. So we need those regulatory frameworks and support, but we need that focus on innovation, on science and research and development. And I think we're going to end with a few final words from Professor Nicaise.
Let's take the picture.
Thank you so much.
Good evening, ladies and gentlemen. Could we take our seats, please, for this session? We'll start by a presentation, and then after that, head into a panel discussion. The panel discussion will be coordinated and chaired by a good friend of mine, Professor Kara Hanson of the London School of Hygiene and Tropical Medicine. But before that, let's start with the presentation, our keynote speech. My name is Moses Alobo. I am head of programs at Science for Africa Foundation, based in Nairobi, Kenya. So for our keynote presentation, to open up this very, very interesting session, may I invite to the stage Dr. Catherine Chobutunji from APHRC, the Executive Director. Catherine.
Distinguished ladies and gentlemen, I'm waiting for my slides to be loaded. It's a great pleasure and honor to be here. And I was going through the program and saying, wow, what an honor to be in such a distinguished group of highly accomplished scientists from all over the world, and also from the African continent. So I was given a brief talk about promoting fair global research partnerships through new funding models. And I first asked myself, why are they using the word fair? I'm used to equitable partnerships. And then I found that actually fairness is what justice is really about. And so in a way, I didn't have to change too much my usual pitch about equitable partnerships. I said fair, equity, same thing. So when I talk about fairness and equity, I'm meaning the same thing. But I found this quote quite powerful because it challenges us that fairness must have an end that is a higher goal, and in this case, it's justice. So to frame my presentation, I have only 20 minutes. I said, let's talk about equity, towards equity and justice in global health research partnerships. And then towards the end, I'll talk about the funding models. And so I think the beginning point is, what equity? And you heard from the introductions that we have different types of partnerships. So when you think about equity or fairness in partnerships, I think once you unpack the different types of partnerships that exist, then you also have to ask yourself the question of what equity are we talking about? This graphic is quite familiar with most of you, I hope. So it starts from inequality, it talks about equality. So inequality, of course, there are things, people don't have access to equal opportunities. Equality is trying to provide equal opportunities for everybody. And if you think about from a funding perspectives, this is the frequently asked questions that we get from funders. So there's a call, it's open, everything is transparent, everybody gets the same information, everybody gets the same opportunity. That's equality. When you think about equity, it is recognizing that this, I don't know whether that's an apple or mango tree, it's tilted. So if you put the same ladder, some people are not going to reach the fruit. So you need a bigger ladder. And that's the question about what within the funding mechanisms or the funding models that exist is equitable. And then at the end of the day, justice. Equity for what? Whose equity, whose justice? Because at the surface, we can focus on equity in the process. And that's what preoccupies us as scientists and researchers, especially in the current environment, equitable partnerships. So that it's equitable, the funding is equitable, the attribution is equitable. But I'm actually sitting in some of the previous sessions to hear this message reinforced over and over again about the need for that. So what is the challenge? I wasn't there yesterday, but I saw from the newsletter I received this morning about the opening plenary, about how from within the EDCTP network, only 3% of paper text in which we want equity. There's another context, which is the fact that in terms of people, capacity, with whom to have equitable partnerships, we just don't have enough. These are statistics that shows Africa has about 90 PhD holders per million. The global average is 1,200. And there's about 200 researchers, health researchers per million. The global average is about 1,150. If you want to know the number for the UK, PhD holders is about 4,500 PhD holders per million. South Korea is about the same. So when we think about equity, who are we going to be equitable with if there are just not enough scientists on the continent? And then this is a graph, a headline from University World News that says universities must strive to produce 100,000 PhDs in the next 10 years. And this is from 2022. You can Google or ChatGPT the number of PhD products a year in the whole of Africa is between 4,000 and 500. And that's because there's actually been a ramping up of production of PhDs. And this statistics actually is aimed at increasing the 90 per million to 1,200. It's not asking for what? It's just about numbers. We need to increase PhD products. Then, of course, there are other parts of the context in which, when you think about equity, and the big question I want to keep asking ourselves is, whose equity are we talking about? And this is a graph about publication. And I tried to look for a more recent graph, but I could only find that one that goes up to 2022, and that in 2022, there were 5.14 million papers published. And the number of journals now is more than 40,000 since, I think, 2019 or something like that. We passed the 40,000 mark in terms of scientific journals. So the number of journals are going up, up, up. Number of papers are going up, up, up. So when we're fighting for equity as scientists, are we fighting to get a bigger proportion of the 5 million papers? Are we fighting for a bigger proportion of something that is bigger? Justice. Are we fighting for justice? Are we fighting for a bigger slice of the 5,000 papers? And an interesting headline which says, scientists are publishing too many papers, and that's a bad thing. It doesn't actually quite speak to that, but I found it is quite interesting. And then we had earlier, I think we've heard from the previous session, the translation gap. If you're in EDCTP, chances are that maybe this statistics does not typically apply to you, but I'm talking about the broader context, the fact that we have a big translation problem. 17 years on average. There's an updated analysis which has put that at 12 years. It takes on average 12 years for innovations to move from the lab to any kind of action, a policy, a program, a guideline, an innovation. And then this is quite more recent, 2023, only 14% of applied health research innovations are translated into anything beyond a scientific paper. Again, equity for what? So what are some of the other contextual factors? And that's, again, when you think about equity and the dimensions in which we can think about partnerships, the fact that within the African continent, we have these structural inequalities. We have geographic disparities. We have institutional concentration. We have language barriers. My slides have been distorted somehow. But geographic disparities, 10 countries in Africa account for 70%. That 1 to 2% you saw, it comes from 10 countries. 70% of that comes from 10 countries. Institutional concentration, if you're not in a capital city, if you're not in a big city, then these statistics of 1 to 2% don't apply to you. You know, your contribution on average is less than 1 to 2%. Language barriers, 70% of papers from Africa are published from English-speaking people. And then funding imbalances. This was talking about HIV. HIV, malaria take 65% of funding that comes to the African continent. So when you think about equity, equity goes beyond, I'm working with partners from a different part of the world, and I want an equitable share of the attribution of the resources. We think about equity, there's actually issues of geographic inequity on the continent. And then, where does the money go? This is what I just talked about. At the bottom, 65% of the funding, HIV, AIDS, and malaria. At the top, 1% of funding goes to mental health. And that has nothing to do with the burden. HIV, AIDS receives 65%. 37% of deaths on the continent are from NCDs, which receives 2% of funding. How does this happen? One of the root causes, low domestic investment. And the African average of investment as a function of GDP is about 0.45%. In spite of our government signing commitments, I think now it's about 17 or 18 years, to give at least 1% of their GDP, which is the AU target. The global average is 1.7. So we're in a low GDP economy, and we're giving 0.45% of that. And again, when you talk about differences within the continent, Mauritania is 0.01%. I don't know what the GDP of Mauritania is, but they're only giving 0.01%, and then South Africa is the one that is closest to the 1%, which is 0.85%. So when you think about equity, part of the issues is how do we build a system where every country maybe can see that 0.85 perhaps is something to aspire to. When you think about equity, how do we get Mauritania maybe to reach the African average of 0.45? Because if you're not in Mauritania, if you're in Kenya, if you're in Egypt, if you're in South Africa, if you're in Uganda, you know, the R&D ecosystem is fine. If you're in Chad or Malawi or Mauritania, where they're putting 0.01%, if there's somebody from Mauritania in this meeting, they can put their hand up. I doubt that there's one person in Mauritania in this meeting. And that's a function of the 0.1% that Mauritania is putting in their R&D. So, if there's no domestic funding, what do African scientists rely on? External funding. And actually, external funding reinforces the inequities and the unfairness. And the Global North institutions receive the majority of international funding that is earmarked for Africa. This is not international funding generally that is earmarked. And then they act as intermediaries, so it's very difficult for an African institution to have a direct line to, you know, the funding, wherever it's coming from. And then African institutions are usually positioned as implementers and not as strategic partners. And there are some interesting statistics. NIH Fogarty, if you know NIH Fogarty, yes, 70% of NIH Fogarty funding goes to US-based institutions. And you know what NIH Fogarty is. I don't need to describe it. We have Wellcome. This is not Wellcome generally. This is their international program. 73% goes to UK-based institutions. USAID, that thing that used to exist once upon a time, 80% of US funding was going through US-based institutions. And then the Bill and Melinda Gates Foundation, 88% of funding earmarked for the African continent is going to non-African institutions. So there's a reason why. And when you think about equity, there are those other things. Whose equity? Who drives equity? That all of us have some kind of role to play. And this is an interesting statistic, and I love this headline which says stuck in the middle. Stuck in the middle is a function of the funding. If you receive 20% of the funding, most of the time, it's to collect data, clean it, and make it available. Most of the time, it's not analyzed. Most of the time, it's not engaged with policymakers. So you're given the honor to be part of a paper because you participated in this collection. That's why you get stuck in the middle. And if the middle was a good thing, it wouldn't be a problem, but the middle is not good. And this is a paper from, I think, 2017 or something like that. So there are many papers out there. If you go, you'll find them. This is another one which looks at equity in global research in RCTs, which I would imagine is something that EDCTP would be familiar with. Again, huge disparities in who gets first and last authorship. And part of it is, again, funding. Now, this is an interesting one. Why do we have a global health architecture where the majority of the global health leadership is in the global north? It's because there's a very healthy pipeline. The unequal funding creates opportunities that create a very healthy pipeline of global health leaders. And this is some interesting analysis that is being done by Global Health 50/50, which shows that as an astonishing, if you look at the leaders of the top 200 global health institutions in the world, about 50% of them come from the UK and the US. The top 200 global health institutions, the leadership, 50% of them come from the US and the UK. About 88% of the institutions are based in either Europe or the US. global health institutions. And there's another interesting statistic that 8% of the global health leaders of these institutions were trained in Harvard, and that's the same proportion as those who are trained in institutions in low and middle income countries. So the unequal funding opportunities create a pipeline that ends up in global health leadership. And we could say this is a good thing, or maybe not. Maybe it's a good thing. But there's a reason why leadership, I think, is good. So why isn't the leadership somewhere else? Then there's another challenge, and that is the focus on individual investments. So we have a lot of fellowship programs. We train people, many of them. I was reading the EDCTP report. I think they've trained 229 PhDs over the last 10 years or so. So there's a lot of investment in individuals, but not as much investment in institutions. So we have highly trained institutions on this continent. Some of them have been lost into a system that is dysfunctional. So the thing is, if you want to talk about equity, it's not equity for individuals, it's also equity for institutions. And maybe it's the divide between how much we invest in individuals and how much we invest in institutions. Now, I think the main message really of what I wanted to talk about, whose equity are we talking about? And that's another one of my favorite papers, The Uses of Knowledge in Global Health. And that's an interesting cartoon. They're decision makers, and there's one group up there, and there are many people out down there who are saying, how can we make our voices heard? And the people down could be anyone. It could be southern-based researchers talking to northern-based researchers, how can we make our voices heard? It could be the nurse we heard from in the previous session who is working in a facility treating Kala-Azar disease, not a neglected tropical disease. How can she make her voices heard? To me, the scientist. It could be scientists talking to funders. I don't know. There are many decision makers somewhere, and the question is how do we make our voices heard? But the gist of this whole paper on the uses of knowledge in global health actually is quite profound when you think about it. What it says is that majority of knowledge produced by professors, quote unquote, these are researchers and academics, is used by fellow professors. We produce knowledge for the sole purpose of citing it. Yes, when knowledge escapes from the citation vortex, or whatever you want to call it, it goes to engineers, technocrats, and policymakers in capitals. The nurse that we saw in the previous session on NTDs, if she gets any kind of knowledge that comes from us scientists, it's like a rare thing, it's like a unicorn. So the majority of the knowledge does not reach people who on a daily basis make life and death decisions that we then count and then we make reports. Global. If you're at the global level, you're inundated, you have spoiled for choice in terms of knowledge. If you're at the local, you don't have enough knowledge. So when we are fighting for equity and fairness, we have to ask ourselves, whose equity are we fighting for? It shouldn't be equity for us to have a piece of the cake, a piece of the pie, to put papers into a system to be cited and to cite. It should be equity that actually everybody in the ecosystem that makes decisions can have access to knowledge that allows them to do the things that eventually will lead us to justice. So, where does funding come in? I've not forgotten the new funding models. And really, new funding models, if I was to summarize, of course, we want equity and fairness in the process. So that 80% by USAID, the former, the 73% by Wellcome, we want equity in that process, fair, well and good. We also want within and between country equity. The usual suspects. I can tell you every map that you draw of Africa that talks about research, whether it's investment, whether it's output, whether it's PhD, whatever it is, has the same 10 usual suspects, every single map. So we want equity between countries, but we also want equity within countries, that not all the money stays in Nairobi or Kigali, that wherever a scientist is, they can actually do science because they are actually closer to the nurse that is making life and death decisions. And then, of course, equity in health outcomes. 65%, malaria is a terrible thing, HIV is a terrible thing, but 65% is a lot. Mental health, 1%. NCDs, 2%. We need equity in the way we fund different things. And then, of course, we need funding models that focus not just on individuals, but also institutions. When I talk about institutions, overheads, we get 8%. Did you know? Our overhead is 17, but we get 8, and we take it. We get 13, we get 15. And somehow we're supposed to figure out what to do with that gap. Unrestricted. That's how we build institutions. Infrastructure, policies, structures, systems. We need strong institutions on the continent, and then we need brilliant individuals that can thrive in those institutions, not brilliant individuals that are floating in the desert and worrying how to, put their knowledge to practice. And then, of course, we need funding models that fund knowledge production that is used at all levels, from the nurse, the district health officer, the community health worker, the activist on the street, all the way up to UN, World Health Assembly, and those big meetings, high-level big meetings. Right now, the concentration is at the global level, and there's hardly any knowledge. So we want systems that do that. And I think you heard from the previous session, I think it was the gentleman from Nature. How do we become more impactful? Those things cannot happen unless they are funded. If you fund us to publish papers, of course, then we can keep talking, come for a big conference and talk, but the change and the justice that we're looking for is not going to happen. And so I'll end by saying that we need new funding models that put fairness, equity, and justice at the center. And not justice in process, not fairness in process, but justice for humanity. And my last word is, the best way to predict the future is to create it. No one is going to do equitable things. No one is going to fund equitably. No one is going to share knowledge. No one is going to do a lot of things. It is us. And so if we imagine a future that is just, a future that is fair, a future that where everyone is healthy, we have to create it ourselves. Thank you very much.
Yeah, so thanks again, Catherine, and as usual, another illuminating talk on partnerships. I've got so many questions for you, but because of time, I'll probably just give you one, and then we'll take 2 questions from the audience. The question for me is around power, authority, and influence. There's usually the assumption that, yes, of course, there's a power imbalance, but there's usually an assumption that African institutions, and let me call them out, have got little power, little authority, and little influence. But I know that usually works into the kind of results we see out of partnerships when they actually exert that particular power in one way or another. So I'd like you to think about that. But even before you answer, we'll take 2 questions from the audience. 2 questions. Which hands are going up? And I do hope that we do have a mic. Yes, we have. Question? Am I missing? Okay, there. The lady in a black top. Next question. And the gentleman in a blue top. Right then. So let's hear your questions, and then we will hand over to Catherine.
Thank you so much. My name is Julie Ballin. I'm from Canterbury Christchurch University. Thanks for a great presentation. Just building on the earlier question, so the richest man in the world, who is extremely wealthy and extremely powerful, is from South Africa. I'm just wondering how you might want to, whether there's ways to capitalize on some of the wealth within the continent, and how you might suggest going ahead with that. Thank you.
Okay, that's an interesting question. We will take it. And then the gentleman there in the blue.
Fantastic presentation, very challenging, and we like that. So I'm Pablo Rojo from Spain, and my question is specifically, you mentioned publications and the difference. So, and mentioning it happens, and we are seeing it so much, researchers from Africa caught in the middle. So I like very much how you picture it. But do you have kind of recent data if we are doing a bit better, for example, and because this takes some time, and sometimes the PIs are from the north and so on. So I don't know if you can tune it finally a bit more, but I think it's very, very important. Thank you.
Okay. So 3 questions there. First one on power, influence of African institutions and how that plays into partnerships. The next question was on African philanthropy organizations, if you have any comment on that. And then lastly, publications and issues that the gentleman has brought up.
Okay, I have a lot to say about power. And it's sort of contradictory. The first is that power is taken, never given. So if you're an African institution, you take within the limits of what's legal, but power is taken. And then I was at a recent event where power disparities were described as a function of the gap in wealth and resources. So if you're very wealthy, somebody is not wealthy, there's a huge gap in terms of power. And then that power is both social, it's like a distance. There's a social distance, there's a financial distance, and there's an economic distance. So I think the easiest distance to deal with this is the social, because economic is very difficult. If you're a billionaire, it's hard to think that I can never become a billionaire. But the social, I think, is easier to deal with. So African institutions are stuck in this rut, as I've said. You're fundraising nonstop. Once you fundraise, you have obligations. So the time to create and cultivate the power and influence is very difficult to hive yourself out of that. But the light at the end of the tunnel is, if you're in a system that is not working for you, I think time T0, the system is not working. Time T is equal to 10, maybe 10 years, the system should work better. Because remember, power is taken. So if you can't take power today, at least 5 years, you should take some, 10 years, take more. After 15 years, maybe you've taken everything. Or you've reached a point where there's some, the disparity is less. So I think pushback when people try to exert power should be expected. But if you know that somebody is not going to cede power willingly, then of course you have to figure out how to navigate that. I don't know that that's helpful, but I think it's good to remember that power is taken, never given. Now, when it comes to African philanthropy, that's a very common question. And I lead a research organization that does not produce products or technologies. So I think somebody like that rich South African would find it very hard to see why should I invest in an institution, which tells us the teenage pregnancy rate is 20% and all that stuff. However, I think that African philanthropist might invest in a university that is the village where he was born, or where his wife comes from, or where his mother comes from. So African philanthropists actually are likely to invest in African academic institutions, public institutions, or universities. So if you're a researcher who wants to build ecosystem, I think you can make it possible for this billionaire to give some money to your partner with an African university. And again, it's not something which will happen unless there's a systematic way of doing it. And it's a constant challenge, and I want to put out there for the African scientists. The 0.45% is not going to increase unless there's a systematic way of fighting for it. The African philanthropist is not going to give money unless somebody asks, and asks in a way that is compelling. So there are things that can be done to position African institutions, package your message very nicely, and have a plan. It won't just happen unless there's a plan. But even without those interventions, African philanthropists are already funding, especially academic institutions. So we can leverage some of those things and see how best to improve the ecosystem. Now, the papers, I don't have the latest data, but what I know is that some funding agencies have shifted in maybe I would say the last 5-6 years about the requirements for what is good science. So insisting on equitable partnerships, for instance, how much money goes there, what is the role of the PI and the collaborator. Some funding agencies have done that, but I think what they've not done is to go deep and see, the African partner, do they have money to pay for people to publish, pay their time, a scientist? If that's not happening, I don't know. And since this is like a 5-year sort of development, I think we'll start seeing a shift in those distribution of publications. I lead a research organization. When grants come and the grant closes, the person who publishes the paper from that grant is doing it in their free time. And that's what I say, build institutions. If I had unrestricted funding, I could pay this person to analyze all the data that came out of a study and publish it. But if I don't have unrestricted, and they're being funded by a new project, then we'll keep running, collect data clean, stuck in the middle forever. So I think things have changed, but I don't have the latest data. Yeah.
As usual, thanks again to Dr. Catherine Jobutin. Thank you so much. Thank you. So, may I take the privilege to welcome my co-chair, Professor Hanson from the London School of Hygiene and Tropical Medicine for the next panel. Thanks again.
Thank you very much, Moses, and thank you very much, Catherine, for getting us started. And just to say, it's such a pleasure to be here today. I'm actually here for the UK National Institute for Health Research, for which I'm the program director for the Global Health Research Program, as well as my role at the London School of Hygiene. So yesterday, the minister from Rwanda, those of you who are in this room, told us that we need to go fast and far. It's not just enough to go far. And that's true of global health overall. But he also reminded us that to go fast and far, we need partnership. And in the current, somewhat strained global geopolitical context, resources are more scarce than ever, and therefore partnerships are even more essential than before. So in our research ecosystem, partnerships take many forms. They can be collaborations amongst researchers. They can be the joint arrangements that exist within a funder, like for example, EDCTP, which is very much a funding partnership. Or they could be partnerships between government and industry, where actors from the public and the private sectors come together around a shared goal. And successful partnerships need clear and purposeful parameters in terms of who's contributing and what and how much is being contributed. What are the arrangements for governance and accountability? And how are the benefits going to be shared? Speaking very much to Catherine's comments about the unequal distribution of the benefits of doing research. And all these partnerships, as she said so convincingly, are characterized by differences in power and in influence. But most of the most successful partnerships are ones that, through partnership, generate trust that helps to navigate that redistribution of power. So I think there's a whole story here around how partnerships work and operate in practice and what good ones look like. So in this part of the session, we're going to hear from people who have been involved in partnerships and a range of those different types of partnerships. And they're going to talk about some of the lessons about how to construct and enable productive partnerships. So allow me then to invite my speakers onto the stage. So we have 6 panelists. As they come onto the stage and sit down, I'm going to ask them to each introduce themselves very succinctly. 3 sentences I've given them: who they are, where they come from, and what they do. And then we're going to have a kind of a facilitated conversation across us. So we will be able to unpack and tease out some of these characteristics. So let me start at this end. Magda, each of you to say 3 sentences on who you are so that everyone knows who's in the room. So Magda, if you could start.
Magda Robalo is my name, and I'm here representing the Institute for Global Health and Development, which is trying to reshape the research ecosystem in my country.
Hi everyone, my name is Dr. Lindsay Keir. I'm the Director of Science and Policy at an organisation called Impact Global Health. We're a not-for-profit organisation that focuses on global health research and development. If you know GFinder, we're the organisation behind the funding disbursement data around global health R&D. And for the last 18 months, I've been working with the team to develop some of our African partnerships and hoping that they become genuine partnerships that we'll be hearing about today.
Great. Thank you for having me. My name is Liesel Tsuke. I'm the Vice President of the South African Medical Research Council based in Cape Town, South Africa. We fund, conduct and empower research that improves the lives of those living in South Africa as well as globally. We're also involved in technology transfer, in innovation and capacity development.
My name is Rebecca Grace, and I'm the Executive Director of something called the Pasteur Network. It used to be called the Réseau des Instituts Pasteur. and it regroups 32 national institutions in research, training, innovation, and public health around the world. And I was hired to put in place a new partnership model from the old one.
My name is Jutta Reinhardrup. I am an ambassador of the H3D Foundation based in Cape Town. The foundation is building capacity on the African continent for scientists in R&D, especially in drug discovery. In my previous life, I spent more than 20 years in pharmaceutical industry, and I was leading the consortium for the pediatric praziquantel. And I guess I will talk a bit about this later. Thank you.
I'm Luis Zerbini. I'm coming from ICGB, which stands for International Center for Genetic Engineering and Biotechnology, which is an intergovernmental organization within the UN Common System. I'm the director of ICGB in Cape Town, South Africa.
Great, thank you very much, and welcome to all of you. So let me start then by asking about some innovative partnership models. So Rebecca, can I ask you, tell us about an innovative model and what lessons we can learn from it.
Yeah, so I'm not going to talk about my job. I'm going to go back in history a little bit. And the example that I wanted to use was the meningitis vaccine project. For some of those of you in the room, you may remember this. It started in 2010, and it had some features to it which are quite unique. It was a public-private philanthropic partnership aiming to bring forward a cost-effective vaccine for meningitis A. And today, when we think about meningitis A on the continent and in the belt, among vaccinated populations, meningitis A has essentially been eliminated. But the features of that project were quite interesting. First of all, it involved the Serum Institute of India, so it didn't involve a high-income country manufacturer for the vaccine. It had end-user requirements from the very beginning of the installation of the partnership, which included things like what do people need, what should the dose range be, not the dose range, what should the age range be, how should it be conducted. It had a clear relationship to national authorities, and it started from the ground up. It was also funded completely, which is nice because it goes back to our plenary speaker's example of the need to fund infrastructure, the need to fund more than just individuals. And when we think about large public health success stories, the elimination of meningitis A, at least from my perspective, should be held up as one of the greatest examples in the recent past. And I think it's interesting to learn from those. Of course, there were negatives involved in that partnership. We all learn from history moving forward, but it's something that definitely can be used to look for as an example.
Thank you very much. Liesel, any examples from you?
Yes, no, thanks very much. So when we think about partnership, we also think for the SAMRC, it's really part of our value system, and so very strongly that it's values-based, mission-aligned partnerships. We also think of partnerships in terms of the different cascades. So we heard today beautifully and throughout the conference so far about community-led research. And this is something we take very strongly with an approach that actually roots the research in the community. This also includes going out to community and being driven by community in terms of the findings. We also think that knowledge and partnerships should be bi-directional. This is not only in terms of the community which we work with, but with our funders, with our executive authority, and we work very, very closely with our various ministries. And we've seen actually this play out in the conference today. I think the other thing that we really want to focus on is the concept of co-creation. We've heard about that also throughout the meeting today, and we feel very strongly that a co-created solution, especially to African challenges, is very important. And then a final thing, again, we talked about equity. and how important that is. But we also want to embed equity metrics in a much more strategic and systematic fashion. We heard about some of those, for example, the missing middle or the gap in the middle, but by putting that as metrics, also in the partnerships, we feel that that's much more likely to lead to impact.
Such an important point. If you don't measure it, it doesn't happen. Lindsay, let me come back to you then. Do you have an example for us of a model that really delivered in terms of global health and its features?
One of the things that came to mind when I was thinking about this question was the product development partnerships, which have been running now for about 20 years. And recently at Impact Global Health, we were looking back at the neglected disease pipeline over the last 10 years to see what impact different models had had on the global health R&D system. What we found was that the product development partnership model, and that covers a number of different organisations like DNDI, IAVI, MMV and others, had been really successful at generating the products that we've needed, producing about 70 of those. But if you look at maybe the characteristics of what made them successful, they had a really clear focus. They had a really clear focus on what they were prioritising. They were designed to fill the gaps that industry wouldn't go to, particularly for diseases that just don't really have a champion. If you think about the Brule ulcers of the world, people just don't often focus on that from an industry perspective. They also put access and people at the heart of R&D, which is different from a lot of other models that we see. And I think that's really important when you're thinking about partnerships. It's being clear about what that end goal is. And people, for me, should really be at the heart of what we're doing, as Liesl has said about patient engagement, community engagement. And I think they embed themselves in local communities to try and develop the partnership model to become genuine and to deal with the needs that the countries meet. But I guess just in the current climate that we find ourselves in, these partnerships are at risk because they rely on the public funding that we are losing, particularly through cuts to ODA funding and other funding cuts across the global health R&D landscape. So we're actually at risk of losing a very successful partnership model if we don't intervene.
Thanks, Lindsay. And I've been worried that, in some sense, that the strain that the global financing system is experiencing is going to put some of those equity principles at risk. So I will come back to that question a bit later on. Magda, I'd like to turn to you and just ask a little bit about how do you make sure that global health partnerships are responsive in ways that do align with local priorities and local communities, and how we can bring more local expertise and knowledge into global health partnerships?
That's a very interesting question. I'm older than EDCTP. I'm older than the Global Fund and Gavi and all those beautiful initiatives that were born out of good intentions to strengthen partnerships and make the relationships equal and channel funding to improve lives, increase the number of researchers. I must say EDCTP is a very good model, but it is a drop in the ocean. The overall environment remains as it is. So how do we strengthen partnerships in order to address the needs and the priorities of local communities? Will demand that we change the way we are doing business altogether. Incremental change in 10 years. The minister told us yesterday we moved from 1% to 3% research outputs on the continent in 10 years. It will take us another century, and we will not get to 50%. So, to me, getting priorities and needs of communities to be taken into account at the global level, in global partnerships, demand that we change the relationships, the systems, and the way resources are distributed in order for us to go fast and go far, working together to improve the way things are done. I think we have a bold opportunity now with all that is happening around health funding to reset and then give ourselves the opportunity to really start on a different foot where power is redistributed, not assuming that we enter into partnerships on equal foots where relationships and systems that are enabling or constraining our progress and success are overlooked, and we assume that everything will be fine because we sit around the table and we discuss. This is true for global level and national level, but it's also true for governments, civil society, and communities. We also need power redistribution at that level so that we listen to communities more actively and actually they are at the center. We are far from there, but unless we become more ambitious and accept that what the progress we have had until now is not acceptable, is not sufficient, is not adequate, we will not be able to have global partnerships that actually incorporate the needs and priorities of communities.
You've thrown out a really important challenge to global health research funders, I think, because certainly in my own personal experience, time is an enemy of partnership, right? So tight deadlines, short calls, we've all, I think, been on either side of a last-minute reach out for partners to design a project that really isn't designed with equitable partnerships in mind and doesn't have enough time to really bring in that community and that community perspective and voice. So I think there's a lot of need for us to do things really differently. I'm going to shift gear a little bit now and talk about public-private partnerships. So, Louise, if I could start with you, can you tell us from your experience what role public-private partnerships can play in accelerating progress towards the SDGs? And in thinking about that, tell us a little bit about what the incentives are in these partnerships and what different actors bring to the partnerships.
Yeah, the public-private partnership we call PPP, very important in my view for the SDG, especially in an environment with budgetary constraints. They can enhance infrastructure, healthcare, capacity building, and put on the table the resources that may bridge this gap. At the same time, they may bring different technical experts, which can come with innovation and perhaps with technology transfer that will help this long-term commitment and accelerating the SDGs. Just want to bring a model that we have and that we think it did work quite well recently. It was in partnership with EDCTP. EDCTP has been funding many networks around Africa, and ICGB in our headquarters in Trieste has GMP facilities. And then we partner with them to train African scientists, not just in GMP, but in bioprocessing and regulatory aspects that they need to have in place when they move from the bench to the market. It's been quite nice to have the scientists with us. The feedback has been quite great, and I think it is a kind of example of these public-private partnerships. How they can incentivize, we need to strengthen regulatory aspect, maybe a simple process that can be done. We need clear goals and clear guidelines. We need to bring the private sector to us, maybe give some incentives in terms of international partnership, even in tax. And sustainability, which is in the scenario of the globe nowadays. Sometimes stability is not easy, but that's, for me, it's very important.
That's kind of the world as it is now, isn't it? Jutta, would you be able to tell us a bit from your experience, about your experience of public-private partnerships, the value they bring, and how to make them happen?
Yeah, indeed. And I would focus on what is called product development partnerships, PDPs, because my experience goes back to my time at Merck, where in 2012, actually, not us, but we heard about this high unmet need in young children that suffer from schistosomiasis, that there is no treatment, despite the fact that praziquantel is a drug that was available, but not as a pediatric formulation. Very clearly, when I proposed to my management that we should invest in a pediatric formulation and that it will take only a few years, it's quick, they said, yes, you can do that, but not alone. You need partners for this, and you need the countries, you need the expertise, the local expertise. So we established a consortium, the Pediatric Praziquantel Consortium, greatly supported by EDCTP. What was really important and what was a learning, of course, it did not take a few years, it took much longer. We had many hurdles. We had COVID in between, but we had strong local teams that were able to, we could maintain them. We were able that they could help on the COVID side, and we could resume our studies very fast. At the end, we have a product that has EMA scientific opinion that is pre-qualified by WHO. We are treating the first young children. It's really a success story for all partners. We have ministries of health in it. We have all the PIs, the local PIs, the research centers, but we also need the private sector, and I'm emphasizing this. I don't know how many colleagues from the private sector are in the room, probably not so many, but for product development, you need this expertise.
So getting the right people into the room is important because there's so many different skills involved in going from a problem to a fully fledged and usable solution. Okay, thank you for that. I want to now just shift to research partnerships and the idea of equitable research partnerships. This is very much picking up on the themes that Catherine introduced for us around the profound inequity of many of these partnerships. So, Lindsay, I wonder if I could get you to think from the funder perspective. You've also got you have a background in being a research funder as well as working now with Access Global. So what is it that funders can do not to just enable, but to encourage and in some cases, to encourage and create the conditions where equitable partnerships are the norm and the requirement?
Context, I used to work at the Wellcome Trust, both in the science and innovations team, and thought quite a lot about this when I was there, and I know that is work that the Wellcome Trust and others are still continuing. And it really takes a mindset shift, I think, in order to think about partnerships. It's understanding how the funding systems that we've built lead to and systemically fuel the inequity that we're seeing. It's Catherine's talk was so on point, talking about the unequal playing field, and funders have a key role to play in levelling that, and the first step is really acknowledging it. I'm very conscious that I am a British person sitting here talking about equitable partnerships, and that is a good first step to take for a funder in the global north country like the UK, to acknowledge that, to accept that there are these inequities, and to understand that they have a responsibility to do something about that, to take action to change the systems that we've put in place to make things more equitable. I also think researchers in the UK, the US, and the global north more broadly need to leave their egos to one side when it comes to publications and other things, and focus on what our shared goals are in these partnerships. I've already said we need to put people first, and I think establishing those ground rules in partnerships and what we hope to achieve and what mutual interests we have in a partnership is a really important part of it. There's a session that we'll be speaking at with the Science for Africa Foundation on Thursday, looking at the clinical trials ecosystem, and we'll explore that a bit further and how Impact Global Health is working with different organisations such as the Science for Africa Foundation to think about the data that we need to change that landscape and change that ecosystem to move forward. So I'd love if anyone's around on Thursday to come to that session and help us explore that further.
Thank you. Magda, from the researcher perspective, And really thinking about your position as a researcher in a low and middle income country, what needs to be different for partnerships? And particularly here, I'm thinking about North-South research partnerships. What's needed for them to be more equitable?
I think this is work that needs to be done by both sides. It's not just the Global North, but we need to do our homework. And doing our homework includes ownership and leadership. These are words that we hear every single day, but we don't actually translate it into real action. The Global South, or maybe I should just confine myself to this continent, has what it takes to be investing in its own research, in its own health systems, in its own people, and keeping them on the continent, working and then doing what it takes to move to development. We need to get our house in order. I know that all this might seem so far away from the research conversation we are having, far away from labs, from fields, from institutions, but the macro context is where we need to act in order to change the things we want to change in the field. We need to get our house in order, but we also need to get the power of our voice to change the barriers that prevent us from fair trade opportunities, fair borrowing, and our economic development will depend on how much of those barriers are removed. Economic growth cannot happen if those are not fixed. If we don't grow economically, we cannot invest in health sustainably. We cannot invest in research sustainably. So as much as we would have great ideas on how to connect with communities, how to build labs that are very powerful, and we are thinking about local manufacturing rather than thinking of product development, we need to remember that this will only work if we can grow internally, economically, and invest our own money. Everyone is talking about domestic resource mobilization as if our countries were going to be able tomorrow to get more money to invest into the health sector. That's not going to happen. We are talking about increasing taxes. It's true there is scope for increasing taxes, but we are going to continue taxing the very same ones who are paying the taxes because the informal sector is quiet. So just to say, as much as it might look like I'm talking out of context, just to realize that getting our house in order, an individual, an institution, a country cannot get it done alone. We need to come together as a continent in a very strategic way to solve this and benefit the health of our people.
It's a real call to action, isn't it? Thank you very much for that. And that, of course, is made rather more challenging by the current economic and political upheavals, isn't it? Because there's lots of demands that are being made on national governments to fill all kinds of holes. And I think that will create opportunities as well as challenges, but I think it is a particularly demanding time. So I'd like to just maybe switch to that theme, the idea of making sure that that partnerships are resilient, but also that equity isn't sacrificed in a context of various crises, whether that's climate change, whether it's pandemics, or whether it's political tensions. So I wonder, Lisa, would you like to start us off on that topic of how to be sure that partnerships stay resilient when they are strained?
Yeah,
So South Africa finds itself in a very interesting position, not just because the richest man in the world is South African, but because we're directly facing this onslaught and being targeted more so perhaps than other countries. And what's particularly interesting about that is that the targeting is onto partnerships. So it's partnerships that have built up over years between collaborators, between institutions, between scientists, and this is actively being broken down. And so one of the most important things that we in the MRC is trying to do is to foster new and different partnerships, trying to work together for the country, not just for a particular institution or a particular group, and trying to work within the different spheres of influence, be it in the departments of health, technology, science and innovation, and our general funders, to try and mitigate and rebuild new and better resilient partnerships. And if we think about 3 ways of doing that, and I say this quite unapologetically, it's diversity, equity, and inclusion. And we're thinking about diversity or diversifying funding streams, and how those funding streams work. Equity, and so beautifully illustrated, not just equity but justice, and I don't need to go into that any further, but also inclusivity, which includes integration, the inclusion of lived experience and community, and then resulting in better impact. And I know we don't have enough time, but those are the kinds of things that I think need to be now in the fabric of the new partnerships as we go into this new phase.
That's so important. And it also, as you started to talk, I was thinking also there's always a temptation when under threat to pull apart. And actually what's really important is that we pull together and not feel that the world is a zero-sum game. And the only way under strain my bit of the partnership can thrive is at the expense of somebody else. So together, I think, with those notions of diversity and inclusion and equity, I think it's really it's important that pulling together. Louise, can I come back to you on that as well, about maintaining partnerships under constraint? I think you've got experience actually predates some of our more current problems.
First, I would like just to agree with everything Lisa said, and also congratulate not just her, but Professor Notobek Nutusi. They're doing a great job in this regard in South Africa, which is really commendable. Yeah, for the CGB, we had an experience before pandemic. It means just to show how resilient it has to be, but not just resilience. I think I would like to add just one more point. What Lisa said is the trust. You need to have the trust within your partnership. Otherwise, you're not going to move. Then, for the ones that doesn't know, ICGB is quite unique within the United Nations Common System. We have labs, 45 labs working in different areas of biotechnology, but we also a funding agency. Then we have a program which is collaborative research program. The main point is collaborative. Then we had this program running in our member states. In Africa, it's 24 member states, and they had to work with each other. Then they need to know, they need to work African researchers with African researchers, and we fund this kind of program. Then we had COVID, and then we start thinking what we can do. Then we reach our member states and these scientists that we know, and also the private sector and the foundations, and then New England Biolabs comes on board, where they have a colorimetric assay to detect COVID-19, which is purple, and yellow is positive, which can be done in rural areas. Then immediately we have 5 African countries on board and developing this by the African scientists who already knew each other, they trust each other, they were collaborating with each other. Then in the following year, from 5 went to 9. Then COVID was not gone, it's still with us, but the pandemic ended. And now we thought that it will stop, but the funders decided to keep going. Now we are using the same technology instead of COVID to detect dengue, chikungunya, and other viral diseases. That it means this is still going on. But I have to say that since the beginning, everybody trusts each other. They were tackling diversity, inclusion, etc. But that was an important point for this to still going on.
And it's interesting, isn't it, how trust is both a requirement, so it's both a prerequisite of partnership, but it's also produced through partnership and can be destroyed, actually, through really poor partnership. So that importance of trust as kind of that magic dust that makes things possible when people come together. So partnerships are at the core of the architecture of EDCTP. What can EDCTP do to consolidate its partnership strategy for global health? So let me ask maybe ask Jutta to start and then Rebecca to follow on. Jutta?
Yes, I see. Please wrap up, so we go fast. Definitely, I think the moderator started when he said partnerships, the good, the bad, and the ugly. I was shaking a bit because this is the dogmatism that we unfortunately hear a lot between public and private sector. For me, it's, and that is, I think, really a mandate for EDCTP to bring all these different partners at the table and to create an understanding why has one partner a certain limitation. The private sector acts in a very regulated environment, and sometimes this is not understood by the academic sector and vice versa. So this trust building is essential.
You remind me of something that one of my anthropologist colleagues once said about, it was actually about multidisciplinarity, but the idea that to work together you have to listen to each other patiently. Rebecca, thoughts on this?
Yeah, I want to preface it with EDCTP, I think, has been an incredible success story. So certainly improving upon EDCTP is something wonderful to do. So I just have a couple points about that. The first point is, I'm pretty sure that nobody at the end of their life thinks the last thought that goes through their mind is that they wish they had published another paper. I'm pretty sure that doesn't happen. And so one of the things that could be done within EDCTP is gradually progress further in terms of what they've been doing and move away from an individual model to an institutional one. And there are some really great examples of that. For example, the National University of Singapore has a very interesting model where the way that they create partnerships is to do institutional building, which covers everything from financial, HR, institutional, where the NUS goes to another institution and they gradually hand over all of their procedures, everything that they're doing. The faculty mentors other faculty, and at the end of 5 years, the receiving institution is on their own, and the best part is they pay for it. The second thing I think that EDCTP could do, which we haven't really talked about, or it's a subject which is difficult to speak about, is that, so my current job involves something a little bit different than the plenary speaker. It involves convincing people that have power to not exercise it. And that's a little bit of a different side of this coin. And much of the discourse that we see is about, publicly, is about raising voices, helping people attain their power. But there's another side to that coin, which is encouraging those that have that power to perform what's been termed almost this ruinous solidarity, which is to say to people, well, you know what, do you really need to publish that paper? Do you really need to be doing this? Why are you working on malaria? You've probably never seen a malaria case in your entire life. You may wanna give that up and cede the space to someone else. And then the last area, I think, which is interesting for EDCTP to consider, which they've done many, many things in this area, is I was quite sensitive to the comment about the 10, I don't remember exactly what it was, the 10 institutions that receive the most funding. So coming from former French colonies and Francophone colonies, it would be wonderful to see some specific calls which deal with the institutions which haven't yet been beneficiaries of EDCTP funds, and to have specific calls be addressed to those areas. Thanks.
Thank you. So we are at time, slightly beyond time. We took a little bit of time because we started a bit late. I'm going to call on Moses to come and wrap things up for us. But before we do that, I'm going to put in a shameless plug for the session at 5:30. That's in about 10 minutes' time in MH1. That is about research readiness for response. So Moses, back over to you. Stay there.
Okay, while the co-moderator gets to the podium, I would like to make
absolutely.
3 suggestions to EDCTP as Michael walk out of the room. One is to say that it is time to shift gears. Think about shifting gears. HIV, TB, malaria, yes, they remain important, but there are other things killing people on the continent, and we need to see how do we bring those priorities into the scope of the work. Number 2, Francophone and Lusophone countries also need that kind of support, institutional support, so that we can build our capacities. Third, I think it is critical to bring parliamentarians, politicians, private sector from Africa, Afreximbank, and other African banks to these meetings. I don't want this to become a political rally. We could have dedicated sessions and then they go, but we cannot continue talking to each other. We need also to talk to those who take action. Health is political, and we need to rally them around them. We should consider having specific sessions with politicians so that we move the needle a little bit further. Thank you.
Thank you so much. So thanks again to our panel, and thanks again to Professor Hanson for that beautifully moderated session. Some of the things that I've just picked that I think are important to repeat is that equity and power dynamics is not just a North-South problem, it's also a South-South problem. And we need to bring in and embed equity matrix into whatever we do in our partnerships. Funding designs need to include capacity building, and we need to respond to our constituencies in a bi-directional manner, considering DEI, of course with a focus on locally led indigenous capacities. And then implementation and structures should be able to distinguish between long-term versus transactional partnerships, with co-creation as the base of basically what we are creating in partnerships. And then, of course, a balance is needed where we should be going for shared goals when we are thinking about equity, excellence, and also speed of delivery. And I know the issue is usually on speed of delivery, and it pushes us to actually do some things that we otherwise would not have done. And then finally, we need an alignment with broader research strategies in Africa for us to actually continue building ownership, leadership. One of the interesting things that was said in the panel, quite clearly actually, is that interests rarely change, positions do. So meaning that even if a group is holding a certain position today, please base your arguments on their interests rather than their current positions. Otherwise, thanks again, and look forward to meeting you at 5:30 in MH1 and MH2, where there are other discussions that are going to push these particular discussions to more details. Thanks again. Let's do a photo.